Like Tali said, I am the manager of transplant coordination at Gift of Life. I don't work for one of the hospitals, so that title can be a little bit confusing when you do hear it. Across the transplant world and industry, sometimes the coordinators who work for the organ procurement organizations are referred to as procurement coordinators rather than transplant coordinators, to make it a little bit of a better differentiation. But what we do at Gift of Life, rather than what the transplant coordinators at the hospitals do, is we manage the donation process from the time that the donor hospital calls us all the way through the time that we go to the operating room for the donation process in general. So we work through an initial evaluation phase, the medical evaluation phase. We talk with the donor families, and we then will do some follow-up after the case to let the donor family know what the outcome of the gift that they've given is. So we do work through all the different intricate pieces of the donation process. We also sometimes will go out into the hospitals to help do some education on the donation process with some of our other partners that are in our organization. Later on in the presentation, I will walk you through exactly what it is that our coordinators do from the beginning to the end, but that's just a little bit of background on what exactly my position is within the organization. So I know all of you have a little bit of a different background, whether it be from a donor family, a recipient end, or a healthcare professional yourself. But just a little bit of a background on Gift of Life, if you're not as familiar with us as some other folks are. We're one of 58 organ procurement organizations within the United States. And the organ procurement organizations are the ones that are in charge of coordinating organ donor cases throughout the United States, and they're federally designated. So what that means is that United Network of Organ Sharing designates each OPO, organ procurement organization, to be in charge of a specific area of the country. So for Gift of Life, you'll see in the bottom left the areas that we are designated for, from State College over in Pennsylvania, Southern New Jersey, and Delaware. So being that we're federally designated, we're not competing against any other organization for their hospitals. So it makes sure that the process is just that we're working with the hospitals that we're designated with. So we work with 128 acute care hospitals. We do have 15 transplant centers within our region. And last year, we did coordinate 664 organ donors, which was over 1,800 organ transplants. So we did do the highest number of organ donors within the United States, which is really something to say for our region. It's really a giving region within the United States. And we did also coordinate quite a number of tissue allografts. And I'll share with you guys a little bit later what type of tissues that you're able to donate as well. So also just a overview of what our experience is with organ donation. From 1974 when we started all the way up to 2019, it's really been a lot of growth in the donation experience. And it's not only because of the generosity of our area, it is because also that, as many of you know, transplantation really works. Transplant, because of medications, because of the expertise of the hospitals, it is really an amazing thing. You'll also see that in 1994 is really when we had a big uptick in donation. And I'll explain a little bit later that it's because there was legislation that was passed that required hospitals to begin calling Gift of Life on every potential organ donor. And I'll explain what that potential means as well. And here you'll also see what our experience is with bone and cornea donation. This is also very important donation for people as well. Bone and cornea donation really not only enhances, but I also think it can save people's lives as well. It allows people to come back from injuries, from not being able to see. It allows people to go back to living a meaningful life, being able to work. So it's really an important thing. In 1994, you'll see again, there's an uptick And then in the early 2000s, you'll see another uptick. And that's because of different practices that Gift of Life put into place that was unique across the country, where we began reaching out to families straight from where we began reaching out to families from our office, calling them while their loved one, while they were still in the hospital with their loved one after they had passed away. While it's a very difficult time to do that, it really did improve our practice because the family had not yet left the hospital and we were able to reach them. So as many of you know what the problem is in the United States is we don't have enough organ donors to meet the needs of all the people that are waiting for life-saving organs. We work very hard every day. We try to get everybody that we can off the waiting list. We want to see that everybody gets transplanted. We want to make sure everybody goes home. So we work every day to speak with families and get as many gifts as we can. But the waiting list is very high. And you can see in our region alone how many people are waiting for the gift of an organ and what each one of those organs that they're waiting for is. A majority of the people on the waiting list are waiting for kidneys. And then you can see from there the other gifts that people are waiting for. So to decrease the wait list, there's several things that have gone into place. In 1994, which I had referred to several times, PA Act 102 went into effect. And what that did was it made for the routine referral to occur. And what that did was it mandated hospitals to call with every death, as well as every imminent death. So that really had an increase in our donation activity and lives to be saved. The other thing that it did was it allowed for more funding to occur for the organ procurement organizations within this region, as well as it allowed for people to indicate on their driver's license that they wanted to be an organ donor. So those are some real important things that did occur in 1994 to improve organ donation. Just in 2018, there was an update, I guess I'll call it, to the PA Act 102. It was Donate Life Act 90, which did enhance some of the practices that we are able to do within the hospitals. It helps allow us to work more hand in hand with the medical examiners and the coroners in our area, as well as different ways that we're able to interact with donor families and their hierarchy for next of kin. So there's many legislative initiatives that have been enacted to try to help decrease the wait list and help get more people transplanted. We also try to work on our hospital partnerships. Within Gift of Life, we do have a whole department that goes out and works with all those acute care facilities that I mentioned before. What they do is they go into the hospitals and they go onto the ICU units, and every day they're giving education to make sure that we don't miss one opportunity for organ donation, because one donor can save up to 8 lives, and we don't want that to happen. We don't want to miss one opportunity. So we have a whole department that goes in to try to help ensure that we have those partnerships. And then many people think that individuals have to be young and healthy to be organ donors. But to really decrease the wait list, there's not very many rule outs for somebody to be an organ donor. Many people are surprised to hear that there's no really upper age limit for donation. We hear many people say that, I'm too old to be an organ donor. But our oldest organ donor was 84 years old and they donated their liver, and very successfully, which is an amazing thing. History of diabetes, hypertension, that does not rule somebody out to be an organ donor, medications that they take. Hepatitis does not rule somebody out to be an organ donor. Even HIV now, there's the HOPE Act, where individuals who have HIV can donate to somebody else who has HIV. That was signed into law by Obama several years ago. And then drug use. That's also a common question that we get from individuals. If the person has used drugs, even intravenous drugs, they can still be an organ donor, as we take very, very good care and testing to ensure that that's a safe transplant. So here in our region alone, we're very fortunate to have so many transplant centers to take care of the transplant patients and recipients. We have 15 centers with 40 different programs from heart, lung, liver, kidneys, pancreas. The only program we don't have is an intestine program within our region, but otherwise we have a lot of expertise that is right here for us in the Delaware, Pennsylvania, New Jersey region. So one question that we get a lot is, how do we know there's a potential donor? So all of our hospitals within our region have to call us when a patient has suffered a non-recoverable brain injury. And so that's the type of patient that can be an organ donor. Many times people think that somebody's an organ donor when they've been in a car accident, you know, and they're on the side of the road. But the person that can be an organ donor is somebody who has had a stroke or has had a cardiac arrest and they've lost oxygen to their brain and they're on a breathing machine. So hospitals within our region have to call us when they have somebody like that on a breathing machine, families making some end-of-life decisions, or the doctor's telling them that they no longer have brain activity. And the hospitals must call us with those type of patients. It's a Medicare requirement, and it was also signed into law by that PA Act 102. They also must call us with any death, any cardiac death. So those are the type of patients that can be a musculoskeletal donor, a tissue donor, and give that great gift of bone and skin and corneas. So that's how we know that there is a potential organ donor. And then we're able to dispatch one of our transplant coordinators to one of the hospitals. So what do we do when we're called? So that phone call from the hospital comes into our main building at Gift of Life. And what we do then is we will send a transplant coordinator out to the hospital. That's one of our individuals who's trained in going out and evaluating a donor. And they'll go out and they'll look all through that potential donor's medical record. They'll talk with the doctors that are there. They're going to look and see what kind of history, what all the different medical values are, any different pictures or scans that they have. And then they're going to work with the healthcare team to determine what the best plan is. Has that family been talked to about what is going on? Do they know that this is unfortunately not going to be survivable for this patient? And we'll work hand in hand with that hospital staff to determine what the best plan is to talk with this family. Because we want to make it a team effort with the hospital to make this a positive as experience as we can for the family. It's a terrible time in their life. They're losing a loved one. But donation is something that they can take positive from this experience, and we want to make sure that our approach is appropriate with them. So once the family says yes, then we work with the team to manage the entire donation process. We take over for the next several hours to ensure that everything for the donation process goes smoothly. So once the family says yes, the healthcare team looks to us for what to do next. And we do a lot of different things than what would normally be done for a patient who is being cared for in a way to get better. We do things in a different manner. And what many people think is that when a family says yes to donation and we're going to move forward with them as an organ donor, that things happen immediately. Well, sometimes, yes, that has to happen, but usually the whole thing takes about 24 to 36 hours. So I know some of you who may be recipients may have gotten a phone call and you know that your gift is ready and you went to the hospital and then you just waited. Well, it's because this process takes a longer time because we have to get recipients for all the gifts, and it takes time for all the coordination of all the doctors and all the recipients to come to their hospitals and get ready. So it's not a fast process generally. And so a question that many people have asked is, well, how does this donor and recipient matching process happen? And then we always hear about the list. So you know, people wonder where this list comes from. And it comes from a program called DonorNet. And that was implemented in 2007 by UNOS, which is the United Network of Organ Sharing. And that's a regulated program. so that we can enter all of our information about the donor into it. And then once all that information about the donor is put into it, all the medical information, all the different values about the organ, images, anything that's important for a surgeon or a doctor to know about that, that potential donor gets put into this system called DonorNet. It generates the list that everybody always hears about, and then we can electronically hit a button and that information is sent out to the physicians who are then able to review all that medical information and potentially determine what recipient would be able to get that gift. And it allows us to do that in a quicker manner than it would be if we had to just call people down the list one by one, which in the past, before 2007, is what had to happen. And that was a much slower process for the organ donation, So what is in this this program? I think I mentioned a little bit about this before, but what's in there is it talks about what happened to the person, what brought them into the hospital for this, this terrible end of life situation, all of their medical history that we know of, all social history. I know some of you who have gotten transplants in the past may have been told some about the social history and the medical history of your donor, and that comes directly from what your surgeon learned from this program, as well as talk with our coordinators about the age of this person, their sex, and their blood type. So a lot of basic information, as well as a lot of information about the specific organ that the surgeon is reviewing. So then for each organ, we do specific testing. So some of the routine testing that we do, just in general though, is we do infectious disease testing, which is very important in general, as you would imagine. So we do testing for hepatitis B, hepatitis C, and HIV. So any donor that we have, that is routine infectious disease testing that is done to make transplant as safe as possible. We do routine laboratory tests, just as if you were to go to the doctor and have specific tests done for your kidneys or for your liver or for your pancreas. We do all those type of tests on these donors so that good evaluations can be done by the doctors. We do those laboratory tests though, probably every 4 to 6 hours, because these specific patients, these donors are sick. They've gone through a very traumatic time, and these laboratory tests can change very quickly. So we want to make sure that they're going in a good direction. So we do these laboratory tests very frequently. And then to evaluate the gift of the heart, we'll do an echocardiogram, which I'm sure some of you have frequently. And then for a patient who is a little bit older, and I'm going to use the word older, and I'm above 40, so I guess I shouldn't use the word older, but patients who are above 40 usually get a cardiac catheterization, not to fix anything, but to just make sure that their coronaries, their vessels are clear, so that we know that the heart is going to be able to work well in somebody else. And then CT scans we'll also use to see that everything looks okay and is healthy to be able to be transplanted. And then matching, that's a question that is always asked. So the sickest patients are on the top of the list for each region. I think that's important to know, that we're always trying to get the sickest people transplanted in the most appropriate amount of time. So the heart transplant is determined by status. So somebody who is really sick for their heart would be determined to be a status 1A patient. And that would mean that they're in the hospital, they're connected to a machine, they may have a breathing tube, and they're not able to be sent home. They're very, very sick. And that their doctor doesn't feel that they're going to be able to go home. So they're listed to be a status 1A they're going to be on the top of the list for any donor that's within 500 nautical miles of the hospital that the donor's at. So that's how that process works for the heart. And then it goes down by there from a status 1B, a status 2, and those become your patients who are a little bit less sick. But we want to try to get the sickest patients transplanted first. And the surgeons will determine which gift is most appropriate for which patient. The lungs, the gift of the lungs, the surgeons will give a recipient a lung allocation score, and that score is a medical urgency score, and they take multiple different things into account when they make up that score, and it's really to just determine what the risk benefit is for lung transplant. And between that and how sick the patient is, that's how they're prioritized on the lung list. And the lungs are allocated from the hospital that the patient's at 500 nautical miles out in a circular span. So that's how the lungs get allocated. Then for the liver, they do a MELD score, and for pediatrics, it's called the PELD score. And that's the model for end-stage liver disease. And for that, you also have a status 1A type of patient, and that's a type of patient who is not able to leave the hospital. They have, they've never had any type of liver disease before. They are in real need. They're in a significant medical emergency, and they go to the top of the list. Otherwise, the MELD score makes up the list. The higher your MELD score is, the higher that you will be on the list. And the list also goes by region. So your MELD score would go by the region that we're in. So our area, our Philadelphia area, then out into New York and Maryland are all mixed into one area, and then it goes further out into the nation. So it's between the sickest, as well as to make sure that it's being used within a good distance, so that the liver doesn't have to travel very far and it's able to be used appropriately. And then many of you who are waiting for kidneys know that it's based upon wait time, as well as some of the sensitivity that you may have within your blood to be able to accept the kidney. And then pancreas, it's based upon wait time as well. So then what allows for a match? Your blood type. We also do tissue typing. Size often comes into account for lungs and heart. And then that also is the only reason that gender would also come into effect. That sometimes sometimes some surgeons will not transplant a male heart into a female, or vice versa, just because of the size of the heart. And then how that organ is working. It'll depend upon the recipient that they choose for the organ. And I'm sorry, I'm going to go back for a second. And then the blood type is also a very important piece of the matching process. And you'll see that the blood type O, is able to donate to really all the different blood types. A can only go to an A or an AB. B can go to a B or an AB. And then blood type AB, our rarest, can only donate to an AB. So another important step of the process is obviously working with the donor family. And we do have to speak with the donor family to find out as much as we can about the donor. So we do go through a very intensive questionnaire with the donor family about their loved one. And if you've ever donated blood before, you may have gone through a similar type of questionnaire, but we go much deeper into the questions that we ask. We ask about all medical history from birth until the present time. We ask questions about smoking. We ask questions about alcohol use. We ask all questions about drug use. We ask questions about travel. We ask questions about if they have ever had trouble walking, if they've ever had trouble with vision, if they've ever been exposed to rabies. We ask just about every question you can imagine of the family to determine if we, to determine any specific risks. And for those of you who have had transplants, you may be familiar with the term high risk. And that's really from this medical social questionnaire, how we determine if a patient is of the high risk category or not. So then who can be an organ donor is another question that we are often asked. And I alluded to that a little bit earlier. And so the question is, the answer is an individual with a head injury. I think that's what most people always think is, somebody who's been in a car accident and has a head injury. Well, yes, that's true, but that person then also has to be in the hospital on a breathing machine so that the gift of the organ donation can occur, and it can occur in a controlled manner rather than the person being on, the side of the road or something like that. People also think that that's the number one way a person can be an organ donor. And what you may be surprised to hear is that traumatic head injuries are the smallest number of people who are organ donors in our region. Individuals who have had a stroke and individuals who have suffered a cardiac arrest and have had a loss of oxygen to their brain are actually our highest number of organ donors. They are just about tied for the number one type of donors. So it's a little bit of a myth that the person with the head injury is the person that is usually an organ donor. It's usually the medical emergency is what brings somebody to be a donor. And the person, it has to be somebody who is completely dependent upon a breathing machine. And I added that last one there because there's been oftentimes, and there was a question that Talia had shared with me from a list of questions that people had been asking at the family house. And one of them was, if somebody's on hospice, if they can be an organ donor. And we have had that, and those patients oftentimes are not in the hospital, but they have had themselves admitted to the hospital to be organ donors. And those people are individuals who have had a spinal cord injury, or may have had ALS or something to that effect. And they're completely dependent on a breathing machine. And we have been able to go through the donation process. And it's a process called donation after cardiac death. Because they're completely dependent on the breathing machine, we're able to make the donation process occur for them. So that's a different pathway for donation, but that type of person can also be an organ donor. So a very common question is also, how long can the organs be outside the donor before transplant can occur? So the kidneys can be outside the body for about 24 to 36 hours, lungs about 8 to 10, heart 6 to 8, liver 10 to 12, and the pancreas about 10 to 12. Something newer that's been seen in the transplant field is that they've started using what they call ex vivo devices, which are little incubators or pumps, I guess we'll call them, that they can put really all of these organs on besides the pancreas to extend that time frame. So any of these organs can be put on one of these devices and can expand the time. So the liver can be on there maybe up to 24 hours. The heart can stay on it for about 12 hours. The lungs, probably about 12 to 16 hours. And then they can also watch and see how these organs or these gifts are doing on that machine and make a better evaluation to see how they'll do after transplant. So that's something newer and more upcoming in the transplant field as well. And then, a good question too is, how do these organs get to your transplant hospital? And the answer is because this is such an important gift, and it's such an important thing, is that the doctor who has reviewed the information and the transplant team, it's such an important thing, they'll go to the donor hospital. and go get that gift on behalf of the recipient. So in the donor operating room, we'll oftentimes have 3 or 4, maybe 5 different surgeons from 5 different hospitals coming and getting these gifts on the behalf of their recipients. So that's how the gifts get back to the transplant centers. The doctor comes and gets them and brings it back. And then the donor family. Donation doesn't happen without the donor family. So we'll talk with them. The transplant coordinators from Gift of Life are the ones who speak with the family. And we talk with them after they get the poor prognosis or the time of death. We give them some time, and then we have that conversation with them. A lot of times families bring up donation, more so recently than they ever had in the past. And if they do that, we'll talk with them then. And if there's ever a time when donation could be compromised by waiting to speak with them, such as a time when the donor is not doing well with some of their blood pressure or something to that effect, we'll speak with them in a quicker manner, but that is not as often as we would think. And so what we offer to the donor family when it comes to the donation opportunity is we'll offer to them to be able to donate all of the different organs. We offer the gift of bone, skin, veins, corneas, and then the gift of research if something could not be transplanted. And then we ask them if they have any directed organ donations. So more than it ever had been in the past, people know somebody who needs an organ. And the family may then at that point say, our cousin, needs a kidney. And so we'll look into that and see if that person can receive that gift of that organ. And that person would then be able to directly receive it if it was a match. Tissue donation is very different from organ donation. That type of person does not need to die in the hospital, which is what's the biggest difference from organ donation. It's very strictly regulated. It's regulated by the FDA, whereas organ donation isn't. Organ donation is considered life-saving, so the transplant surgeon can make the decision for the risk-benefit ratio, whereas because tissue is considered life-enhancing, while I think that it is actually life-saving based upon what it can do for somebody, the FDA is able to regulate it due to that. And then what is also very unique to tissue donation is, unlike organ donation, where our transplant coordinators will approach the family in the hospital, our call center approaches these families over the phone, whether it be before they leave the emergency department, when their loved one has passed away, which I had mentioned in the data slide when we had that big uptick in our data, or after they've left and they've had time to get themselves together, and we'll then approach them on the phone. So it's a very different process there. And then, what tissues can be donated? Heart valves, which are very important. A lot of children will need heart valves. And what's great about the gift of heart valves is that unlike a mechanical heart valve, which a person would have to take blood thinners for the rest of their lives, the gift of heart valves, of human heart valves, you don't have to take blood thinners. So a child who gets the gift of heart valves can then live a normal life and play sports and do a lot of things that they never would be able to if they had to get a mechanical heart valve. The gift of veins can be used for bypass surgery or to give somebody a graft for dialysis. Bone is used for reconstructive surgery, whether it be athletic surgery or, I've known of somebody who has had to have jaw reconstruction. And they can look very different after that, which is an amazing gift, or even dental dust. Many people have had that and not even realize that it was donated tissue. Skin, I think we've all heard of burn victims who have needed the gift of skin. But something I didn't know till a couple of years ago is that it can also be used for women who have had mastectomies to reconstruct the breast, which is pretty amazing. And then the gift of corneas, which can give sight to somebody else. And then the gift of research. which is something near and dear to my heart because I coordinate that for Gift of Life. But what I always tell families is our goal the day of the donation is to get somebody transplanted. We want to save a life that day. But for some reason, sometimes an organ cannot be able to be transplanted. And then that gift can be given for the gift of medical research. And we work with very specific researchers who we've had time to work with and get to know. And they are doing specific projects that can either help medicine in some way, or mostly transplant is what they're working with. And by giving that gift, they're helping more people than they would ever know on that given day to improve the field of medicine, specifically transplant. And then just some other gifts to note. We don't do these very often, but we participated in our first bilateral hand transplant with the University of Pennsylvania in November 2011, which was a very unique experience. We worked with the University of Pennsylvania in January 2020 for their first uterus transplant. And then we were also a part of the first African-American face transplant in the fall of 2019. So those are some other pretty unique situations that we've been able to be a part of. And then just talking about some of our experience with donor families. It's hard to think sometimes about what it's like being in, somebody's shoes at the end of their loved one's lives. But what's really unique in the experiences I've had with any donor family is once you've talked with them about donation, they're extremely invested in that process. And anything that you let them know about what's going on, moving forward with it, they really are invested in it. You let them know that you found a recipient for one of the gifts, and sometimes they break into tears. That they're so grateful for being able to be given that opportunity for being able to give a gift to somebody else at the end of one of their loved ones' lives. And they really, they feel like it creates a legacy for a loved one. And so many of them say, so-and-so would have really loved this. I'm so happy we're able to do it for them. And it's amazing to see, what these donor families hold on to with donation. So, any recipients, just know that these donor families, are just, even if you haven't heard from them, many of them, have said to me, I don't know that I could ever write to them, and I'm okay if I don't hear from them. I just really want them to know that I just really want them to do well. So the donor families are really an amazing group of people to work with. So then some things that we do post-donation. We have a group of family support services, counselors that will reach out to the donor families at different time periods and help support them through the grieving process. And then every fall we have life and legacy ceremonies where we honor the donors from the previous year. And they also get this medal that you see below. And that medal can actually be put on a grave marker, or the family can just keep it. And they also get little pins that are the same as that medal. So that's a nice thing for the family. Then just to go on to several questions, Talia had given me a list of questions that she had gotten from some people at the family house that I'll just go through quickly in case any of you guys were the ones who had asked the questions. So one of the big ones is what if it's on my driver's license? So the answer is they'll save you. Don't worry about it. The hospital can't access the DMV. And the organ procurement organization or Gift of Life or wherever it is that you may be living at the time are the only ones that can access the DMV to know that you're an organ donor. So the hospital wouldn't even know it. So it's a good thing to put it on your license. And by doing so, you're making that decision to be an organ donor yourself and taking it away from your family to have to make a decision like that in the end of your life, and taking one less stress away from your family. Then some other donation questions that I got from the list Talia shared with me is, will funeral plans be affected? Meaning, time frame. And then some people always ask about an open casket funeral. Um, so like I said, the donation process can take about 24 to 36 hours. And we work very closely with the funeral homes. So usually the time frame is not affected for a funeral. And families can have an open casket funeral. I always tell families, if you didn't want somebody to know that their loved one was an organ donor, you would never know. So that would never affect the funeral plans that you would have. As for an autopsy, many people are surprised to know that that can occur. We work very closely with pathologists as well as medical examiners to ensure that both can occur. We make sure that we can take pictures, we can do biopsies, we can call them from the operating room, and we do both things very closely together. Because it's important, if there is some sort of suspicious death, that we ensure that everything is being done to help with that investigation, but as well as saving lives through organ donation. And then I think we covered this one, but does the person have to die in the hospital to be an organ donor? So yes, that answer is yes for organ donation, but for tissue donation, they don't necessarily have to. And then some recipient experiences and questions that I got from the list Talia had shared with me. I think some people asked, that they were called several times prior to receiving an organ and kind of put on standby, and they were wondering why that occurred. So what happens is, and I'm going to use the gift of the liver as an example, is, there'll be a recipient for the gift of the liver, but we want to make sure that because that gift is so important, if something happens to that first person, that we have somebody else all ready to go, so that gift is able to be used. So sometimes we do have more than one person all ready to go, because we want to make sure that every gift is used every time. So, oftentimes there are more than one person in a position where they're ready to go because of that. Some people have asked why there's so many tests required to be listed for transplant. And that's because the transplant centers want to make sure that the person who's getting the transplant is as healthy as can be besides the organ that they need for transplant, so that they have a good outcome after transplant, as well as have a good support system after transplant, because both are very important. If you're getting the gift of a liver and you have a underlying cardiac problem that you don't know of, that can be problematic post-transplant. So that, is very important as well. And then why are some people transplanted faster than others? We talked about the lists a little bit earlier, and how, just because of the way the different algorithms work, and, how sick people may be, it can cause how the lists change. And that's why. And then as recipients, I know some people ask if they can be an organ donor, and the answer is absolutely. There's no reason that you can't be. So, put it on your driver's license.